just think the level of care is going to be much more superficial. Obviously, someone's going to chime in with, oh, I go to an HMO and they're wonderful to me. But by and large, I've worked in both models, and I know that your economic incentive is to not perform and not do and not refer any more than necessary, quote unquote, in that HMO environment. So I would say consider the type of insurance you're being offered, and if you have a choice, opt for some type of fee for service.
I know there's also a lot of problems with like medical records and, uh, you know,
What do you mean problems with medical
like
records?
overwhelming amounts of medical records and not being able to access them.
Well, I think that each person should act again. If they're going to be the central actor in their own management, they need to retain copies of all medical records whenever possible. Now, walking out of a doctor's office or specialist office and asking for copies of everything that was done is sometimes um, dicey. Sometimes they don't want to do it. They don't want to take the time to do it, or the expense. They may charge you. But if you go from doctor to doctor, you're really not going to have your medical records. We don't have electronic systems that talk to each other right now. Many of us have electronic medical records within our own office, but actually communicating from internist to diabetologist to rheumatologist to pulmonologist is not something that's going to happen unless you're carrying records. So I find myself constantly asking, well, you saw the cardiologist last week. What did he do? What did he say? Did he change anything? Did he? And if they had come prepared with that information right up front, that would have saved a lot of trouble. Someday that communication will be better, but you have to presume that each of your doctors doesn't really have a good handle on what the other doctors are doing or recommending.
Right. So how can we like make the most out of a doctor's visit?
Well, like I said, the first thing is come prepared.
Mm-hmm.
If you have up to date information on your own particular problems and medications and history, and especially any interval history that's occurred since the last time, um, that will help enormously. We're taking notes as we go along, but it's nice for me to be able to spend the time on new problems and new thinking rather than going over recording history. And so, whatever time I have allotted to the visit, if I'm spending it, writing down, where have you been? What was the lab? Did they do an EKG? And what was the result? If that's presented to me, it makes things enormously easier and more productive for that visit.
And so we have, if you go to the handout link on the website, there's actually a form there that's a doctor's appointment form that will give you a whole recap of what you need to remember when you go into the doctor, um, important questions to ask. Make sure that you walk out of that visit with all the information that you need with nothing forgotten.
Right. I think those are useful guidelines. It's not the only way to draw it up, but it does give you some ideas of the information that's important and necessary to bring to each visit, and not assume they're going to know that or they're going to have that at their access, and then, of course, waste time catching up on past data. I think that's really a point we should underline throughout this discussion. If you have a allotted amount of time face to face with the doctor or the medical staff, you really need to maximize that time. So you have to have a strategic plan. If you were going for a job interview or anywhere else, you'd come prepared with documents and things to present to them. And I think being at the doctor is no different. But many people show up, they don't know their medications. Oh, I forgot the bottles. I don't know what the list is. I'm sorry. Somebody gave me a prescription. I'm not sure what it's for. And those things are just spinning of wheels, and time is going by, and pretty soon that's the end of the visit by the time you straighten out those little things. So being prepared, old Boy Scout motto, be prepared, that's still pertains. You come with all this, with all the data and the goods, and I can be more productive.
All right, so let's go back to medical records for a second. Um, so, what are your rights to medical records as a patient?
Well,
Your
certainly
medical
everybody
records.
has the right to their own medical records, absolutely. Now, states we're in Florida. The Florida state law, I believe, documents 10 cents a page for a copy of your record. You may have to pay for it, but it's something worth keeping and something um, it, worth presenting to the doctor when you come. So you should have a copy, and you should be prepared to give them a copy when you get there. So that's money well spent, definitely. But you certainly have the right to your records, whether they're electronic and accessible through a portal, or if they're paper copies.
Now, you told me something interesting yesterday that I didn't know because I have paid money before, a lot of money before, for being able to get my medical records. What's the law about how much you're supposed to pay?
Like I said, Florida has a statute. I don't know what the statute is, but the lawyers send copies of it to me all the time. And it says 10 cents a page um, for copies. I often seen people charge $1 a page,
Yes,
which is
I've been
pretty
charged $1 a page before, and I didn't know that that was
right. They can
illegal, so
try.
that's
Now
good
each,
to know.
I'm sure each state has a statute, so you can certainly look that up on your online, but it's not excessive. I would say 10 cents or 25 cents is probably
Okay.
fairly standard.
And so, as far as keeping them organized, I know that there's a couple of programs coming out now that handle all your medical records and just put them all together online for you to access. There's even a program now called CareSync that I was able to check out that will call all of your doctors and ask them for the records, and they'll fax them to them and they'll put them inside of a portal for you to see and access. And I think that's really important because, there were things that I was noticing that I had gone to so many specialists and my files were being passed around, and I didn't realize that someone along the way had diagnosed me with something that was not what I had.
Not really your disease?
Yeah, no.
Somebody else's disease?
They said I had Ehlers-Danlos, and I had never been diagnosed with Ehlers-Danlos. So that was in my file, and it was going around to all my specialists, and I had no idea.
Well, in a perfect world, we would see our records constantly, review them, and correct them. I don't know who you'd go to correct something like that because it's sort of out there now, sometimes in cyberspace. But you mentioned, what's it called? CareSync?
Yeah.
CareSync website to me that actually communicates to doctors' offices and uploads records of various things. That sounds great in theory. I hope that develops over the years. But, I can tell you that as a doctor's office, when a patient comes, we often call other doctors' office specialists and try to get copies of things, and we can't get them. They say, oh yeah, we'll fax it to you. Oh yeah, we'll send you a copy. And of course, 2 and 3 calls later, sometimes we get it, sometimes we don't.
I know
So,
CareSync is obnoxiously persistent.
well, they better be because you can't just ask once.
Yeah.
Sometimes you get the low-hanging fruit. You might, you get some people to respond, but some offices are notoriously unresponsive. And I guess if you have a choice of doctors to go to, I wouldn't go to a doctor's office that was unfriendly, unresponsive, uncooperative, doesn't return calls, et cetera, et cetera. I mean, that seems relatively self-evident, but as behind the scenes, I can tell you that the attention to your case is equally sloppy and superficial. So you're really not getting great value in an office like that. So I think you should take your cues from when you first walk into a doctor's office. How do they treat you at the reception desk? How does the nurse act when you go back? Do they seem organized in terms of where your records are? You're going to this office, doctor be right in. And all the things down the line, I think you should be, critically evaluate how the encounter is going, because that's how a lot of your care is going to go, or
So,
lack of.
say you're you're stuck with a doctor, because we have Angela
Stuck?
Adler. Stuck. Yeah, Angela Adler here has a doctor, and she's having a problem getting blood test results from her in particular. And she took about 10 vials of blood, and now she can't get these results back.
Really?
So, yeah, what is she supposed to do?
Well, when they took all the blood, do they immediately schedule a follow-up visit? And that would be relatively reasonable if I suggest to somebody I'd like to get these tests, and then I'll see you in a week or 10 days when all the results will be back.
Yeah.
That's not unreasonable because, I've always found over the years, again, looking at lab results on a paper and trying to remember, who is this? What's their problems? What am I going to do about this now? is much easier if the person's sitting in front of me.
Yeah, and she's saying she never called with the results and you can't get her to call back. I guess that's something where you have to go into the office and make an appointment, make a follow-up.
Either you, again, you or an advocate, if you don't have the strength or energy to advocate for yourself or go in there and um, you know, seriously request that you get follow-up results, then someone has to do it for you. But obviously, that's not appropriate to take numerous tests and then not follow up on the results. And obviously, that's not good medical practice.
Hmm.
So again, if you say you're stuck with, I assume you're on insurance and there's only one physician in the region that's on your plan or something, then you have to talk to the doctor. I think I start with patients come into the exam rooms and tell me, when I call your office, I don't get this, or the nurse doesn't do that, or I think it would be better if I had access. And I listen and I say, okay, that sounds reasonable. Let's do that, or let's make sure that patients are getting this information or whatnot. And if they don't do that, you know right away that you have a problem, doctor. So again, I would be suspect of basically everything they do, both medically and professionally from there on.
Well, someone takes your blood and you don't get the results back. Is it ever? Can you get it from the lab?
You can't, the lab won't give it to you directly. They really have, um, they will really stonewall you. Perhaps you could get it by some type of demand letter or something, but that's
What if
pretty
you went to like
excessive.
a new doctor and could you get those same
Well,
results
the new
back?
doctors, the labs are very difficult. I've found I cannot get lab work that was ordered by another doctor from the lab, even myself. I have to
Interesting.
get it
Okay.
from another physician. So if the guy next door orders lab tests on you, I cannot call LabCorp or Quest or whomever and get results. They consider that to be some type of HIPAA violation, which is a Privacy Act.
Hmm.
And there's a lot of HIPAA um, laws and violations that occur. So everybody is trying to err on the side of privacy, but at the same time, it makes it difficult access oftentimes. So
Really, the point is, if you have a doctor that is that disorganized and they're losing your blood work and they're not calling you back, it's time to switch doctors.
if possible, again, I would say so because when I do lab work in my office, it's either done before an office visit, and then if the office visit doesn't happen for whatever reason, we have a certain file, and I say to my nurse every day, we have labs here, this person doesn't come for a visit, what happened? Or if I see somebody and I need more tests, we arrange a follow-up visit or some kind of follow-up encounter so that it's just not left to chance. It's programmed into the system somewhere so that we have follow-up. And I mean, if there was a reason for me to get those lab tests, which presumably I'm taking blood out of somebody for a reason, then there's a reason for follow-up. So getting tests and not having any follow-up is really not good practice, obviously. So
So let's talk about medications and who you should ask what, because a lot of patients don't seem to know that it's not just your doctor that you can call and ask about your medications. You can also speak with a pharmacist. So let's go through these questions and see which ones you would ask the doctor or you would just be able to ask your pharmacist.
well, I think the pharmacist is a good resource. They seem to enjoy talking with the patients about the medications and what do they do. It's difficult to read a PI or product insert or a generic description of all the effects and side effects of the medication and really process it. What you need is a layperson's description of why am I on this? What is it supposed to do? And I think that one important point I'd like to make about medications is, as a physician, I don't think about medications in pigeonholes or categories. I don't think of a medicine as an antidepressant, a blood pressure medicine, a diabetes medicine. I think about all its properties, what the person in front of me has, and how it might help them. So I frequently get this comment, why am I on a blood pressure medicine? I don't have blood pressure. And I say to them, that's not a blood pressure medicine, that's a beta blocker. And beta blockers have a host of different properties. And I'm using it in you because of this particular property, and this is what I'm hoping to accomplish. And I explain that to them. So don't get hung up, please, on categories of, of what a medicine is. And frequently friends and relatives will say, well, why are you on, an antidepressant? Why are you on a seizure medicine? Why are you on a diabetes pill? You don't have any of those things. And of course, if the doctor had just explained to you, I'm giving you this medicine because it does this, and this is what I'm hoping in your case, that would save all of that consternation where people go, well, why are they giving me an antidepressant? I have low back pain and, pain going down my leg. Well, that might be the indication. But so again, I don't think of medicines in pigeonholes. I think about their properties and the potential for treating conditions and try to match them up with what the person's got that's sitting in front of me. And of course, get feedback on how did that work? How did that interact? How did you feel? And then follow up on that line of therapy or give up on that line of therapy. But it's not about classifications. Certainly not in the 21st century anymore.
So this is a good question. So if you're on a medication and the insurance suddenly decides to stop paying, is there anything that you can do that's, I mean,
This is a real problem for medical offices. Again, in 2014, 2013, we're getting so many insurance company requests for further information, justification, fill out forms, and it's soaking up more and more of our day. And so when we have to prescribe a medication and then find out that, have I tried, get a form that says, have I tried all the other medicines in this class? Has this person ever been on this? And ad nauseum, that again burns up a lot of the time and energy that we have to devote to your care. So, first thing I would say is if you have a drug plan and it has a formulary and you can download some of the common medicines and bring a list, that would save an enormous amount of time because, for instance, if I decide you need a cholesterol lowering medicine and I choose Crestor and it's not on your plan, but Lipitor is, but this, but that, there's a lot of phone calls back and forth time and paperwork that's going to be generated if we just prescribe one medicine that's not particularly on your formulary. If you've been on something for a long time, it's been working, and suddenly you change insurance, which is another common scenario, they may start to deny your medication because it's not on their formula. At that point, you can either, see the doctor and say, well, these are the medicines that are on my formulary. Are any of these equivalent that you would feel comfortable giving to me? Or you have to fight it. And fighting it really is, again, comes down to the doctor's office staff have to fill out papers, make phone calls, and get authorizations. And we spend an enormous amount of time on the phone getting authorizations. And it's very frustrating to us and it chews up a lot of our office time and energy, like I said. So, but that's a fact of life. I think if you came prepared with a formulary, that would certainly be helpful because remember, every single insurance company and Medicare and every Medicare variation have different formularies and allow different drugs. So I could prescribe my favorite, whatever it is, for whatever your indication is, and it could be on 3 of the formularies and not on 5 of the others. And that's very frustrating and, again, wastes a huge amount of time and effort.
do you ever prescribe medications that aren't like FDA approved, and is that okay?
We cannot prescribe something that's not approved by the FDA. We can prescribe off-label. We can take an FDA-approved medication and use it for a different indication. But writing a prescription and presenting it to a pharmacy for something that's not FDA approved will not work. There are special pathways and paperwork. Again, you can get exemptions for certain medications that are available as orphans or special cases. like right now, I'm in the process of trying to get thalidomide for one of my patients, but the stack of paperwork that the FDA requires is about that thick, and just to get the approval, and it'll be a special exemption if that's issued. Like Xyrem, I think you went through a similar thing with the sleeping medication, Xyrem.
Xyrem was FDA approved. It
Was approved, but it was
it
restricted in
was
such a
very
way that you had to
restricted.
go through a
Yeah.
lot of hoops. It
It was
wasn't just a
it was a
simple
training
matter.
program to actually take that medication. You had to actually watch a DVD and answer questions, and you had to be really
Right.
prepared. And there are some patients. There's Angela saying that she buys Dober. What's that one? Doberdine.
Domperidone?
That's the one. The one that sounds like fancy champagne.
That's for your stomach, right?
Yeah, for her daughter in Canada, and now
Right.
buying Xifaxan and Transderm patch there also.
Right. Well, sometimes you can go outside the country, and sometimes they'll require a doctor's prescription, and they'll ship it to you, and sometimes
Is that illegal?
it's sort of questionable, but it's done. You know, it's
Yeah.
shadow, and it's done. So sometimes they'll fill prescriptions without a prescription. Sometimes they just ask, we send a prescription, which we do, and patients will get the medicine that's presumably pharmaceutical grade and presumably legal to ship, I guess.
Mm-hmm.
I've seen some phony medication show up from Canadian pharmacies, but I've also seen most of it has been good, reliable medication, but vastly cheaper.
So some of these questions like, what does this medication do? How much will it cost? What are the side effects? How long will it take to start working? Some of these, if you don't have time to ask your doctor during a visit, you can always call any pharmacy, right?
Well, absolutely. You can talk to any pharmacist who has the time, either in person or by phone. They'll be able to answer certain questions like how much does it cost? What's the typical dosage? Is this, is it used safely in conjunction with the other medications I'm on? Or I'm allergic to certain substances. Is this fall within that group? Is it a relative of something I'm allergic to? What do I do if I have a reaction? Those types of problems. But to ask a pharmacist a clinical question about what is this medicine supposed to do and how am I supposed to feel after I took it is a stretch. They really don't have any experience treating patients.
Mm-hmm.
They get stories over the counter about what happens when I took this, that, or the other thing. So they have anecdotal experience, but treating somebody and then seeing what happens to them is.
They're good for, like, say if you have a problem, it's 2 a.m, you have a migraine, you just started a new blood pressure medication, and you don't know whether or not you can take a
pain pill or something.
Pain pill, yeah.
That's what I said. They're good for interactions and allergic reactions and what have you. So if you think like you're having a reaction to something, or you want to know if you can take something and will it be compatible with your new medication, absolutely, that's a great resource.
And you can call any CVS middle of the night.
Yeah, and they have nothing to do. Yeah, they'd love to talk to you in the
just
middle of
ask
the
to
night.
speak with the pharmacist, and
Absolutely.
You also showed me the interaction calculator on WebMD.
Right, so WebMD has a very nice interaction medication calculator. You can go there and you can type in the name of your medicine, enter it, and then type in the name of a second or a third or more, and it will give you a very nice listing of the potential interactions, side effects, and what to expect from using those two medications together. I use that myself sometimes to see if there's any obscure interaction that might cause problems when I use medicines that are somewhat esoteric or off the common path. And I found it pretty reliable.
Okay. So let's talk about caring for a child with chronic illness.
You want to talk about that?
Sure. We've been discussing this week as far as like how to manage school and educational options, how to advocate for your child in the doctor's office and emergency room. Now you had talked about this with me a little bit as far as parents coming in who have children that have chronic illnesses, maybe diagnosed or undiagnosed at that point. And I had asked, well, is it something you hate to see? Is it like helicopter parenting?
What do you mean?
Like
what I hate to see?
Like parents who come in are just like asking a million questions or.
I think it's very wise. I mean, understand, I'm an internist. My youngest patient is 18. By law, we don't treat anybody below 18. Um, but in general, of course, the mothers are over 18, and they have to stay. Mother and father have to stay involved in advocating for the child because certainly the child can't explain everything that's happening to them or has happened to them. And vis-a-vis that, I think having an extensive and comprehensive family history is really important. That's not necessarily always emphasized so much, but knowing the family tree and all the diseases that have happened because something skipped generations or come from an aunt or an uncle or something and get neglected. But I find myself asking those questions all the time. Does anybody in your family have whatever, ankylosing spondylitis or Crohn's or psoriatic arthritis? And then they go home and ask questions. Of course, that takes time. All of that is time spent and wasted. If it was on the paper when they first came in, I'd say, oh, look, two of your aunts and one cousin had, this glycogen storage disease. I think we should look into that.
Yeah, that might be important.
That's very important information, but like I said, often gets neglected.
Right.
So,
if you look at the handouts online, we have a page in there for 2 pages in there on packets for dealing with school and chronic illness for children. If you've never heard of this before, it's definitely something to check into if your child has any sort of chronic illness. They should have a 504 or an IEP, which is an individualized educational plan. And it's kind of a team effort. It's the parents work with the school, work with the child, and you have to communicate that your child has an illness and needs support. Otherwise, schools will not offer it. It will not be presented to you. You have to go in and ask for it.
So you're making arrangements for a child who might be absent frequently with disease or can't always stay the full hour or pay attention.
Right, and this is by law that public schools in the United States have to provide this. Private schools don't.
And what about colleges? What about at that
colleges
level?
also have to provide disability support, and they usually have centers for student disability that offer things like if your child needs a note taker to help them, or any kind of like deaf or blind support. But there are services available for students who just have chronic illnesses like autoimmune diseases and fibromyalgia and dysautonomia. One thing that I think there's a lot of questions on is when should I consider alternative schooling options for my child with a chronic illness? When a child grows up with a chronic illness, it's hard to tell what is normal for them and what is becoming too much of a strain for them. So the way that it should be measured should measure by days absent. If students hit the truancy mark, which it's something like 30 days of missed school, then it's time to start considering alternative schooling options. And there are so many these days. There's hospital homebound programs, there's expedited educational programs, and there's lots of other homeschooling and online schooling options out there available to kids. This is not something that your child has to suffer through in school every day if their illness is.
So we're saying the modern system, it's not like it used to be. If
Yes.
you were sick, you had no excuse, or you missed too many days. They just simply left you behind a grade or didn't promote you, and no one really made concessions for exam makeups or getting homework to you or whatnot. And now that's much more progressive, apparently.
Yeah, now it's protected by law that you have to
I'm
have the
protected by
same.
law. Hooray.
Yeah, so there's a lot of resources for that on our website. You can go ahead and check that out on our support group handout page.
Beautiful.
Yes. Okay, so let's discuss, is my chronic disease under control? How do we know?
That's a big issue there. If you have one chronic disease, let's say you have Crohn's disease, an example. I guess the symptoms in your intestinal tract, inflammation and pain and diarrhea and weight loss, will tell you whether it's relatively under control. Obviously, we have laboratory parameters we can use. When someone comes to me examine them, make notes, do labs, urinalysis, whatever is appropriate, perhaps CAT scans, X-rays, etc., and try to keep a running tally of how the activity is going. People, I think one thing that we fall prey to is a second disease or an intercurrent condition may come along and you assume it's
Part
the
of the
first
disease.
condition,
Mhm.
and it gets ignored for a while until somebody stops and says, "Hey, wait a minute, I never had this before, or I don't think this is part of my Crohn's disease," and all of a sudden, I've never had this situation where I had to go and urinate 20 times a day.
Mhm.
Suddenly, diabetes has popped up or something else, and you're not suspecting it. I found that the specialist doctors are very narrowly focused on what they do, and to the point where most of them really have blinders on, it seems, and you go there for your condition, and that's what they're looking at. So they could be seeing something um, staring them right in the face and not see it. So keep in touch with your internist. I had
Mhm.
this happened to a long-term patient of mine where he developed a lymphoma and started going to a hematologist oncologist and went for 18 months without coming to see me, even though I asked him to please come in. Well, I'm going to the doctor constantly. They're seeing me all the time. Meanwhile, he had developed prostate cancer and died of it, by the time I could finally see him, right in front of an oncologist. So I thought that was weak.
Wow. So you
But
definitely
there's
need
not
to,
doing prostate exams
you
and
know,
PSAs. He's doing lymphoma. So, I mean, you can get that narrow stuff and completely miss very devastating things. So
so if you have a disease like Crohn's, like how often should you be going in and getting that checked out?
the problem is you don't want to spend your whole life at the doctor's office. So
Right.
you may have 4 different doctors who are involved intimately in your care, and if you see each of them in succession, it may be months and months before you get back to the beginning of the progression. But meanwhile, the internist who's supposed to really be helping you manage what everybody else is doing might be out of the loop, and that can prove devastating at times, as I just gave you an example.
Hmm.
So I think staying in touch with your internist or family practice doctor is obviously good. I can keep a good handle on what's happening with everybody if I see them about every 90 days. If they have active medical conditions, if
Yeah.
there's a lot going on or something going on continuously, then I have to refresh
How would you
about.
define an active chronic illness though? Like how often do you have to be having a flare up or needing a change in medication or
I think having any disease activity on even a day a week every week is significant because if you have any symptoms other than I feel perfectly fine, I'm at my baseline, and every once in a while I have a few days of diarrhea, that's not a lot of disease activity. But if there's some activity fairly often, like I said, maybe once a week, maybe once every couple of weeks, that says to me something is perhaps brewing beneath the surface.
mhm.
And it's those beneath the surface things that you have to watch out for to be proactive. I
And
mean, if you
so yeah.
continuously want to be reacting to catastrophes or crises, that's one kind of medicine, but that's not
And that seems
preventive or
to that
proactive
seems to be how a
medicine.
lot of people with chronic illness tend to take care. It's like they act on emergencies but don't do much proactive treatment.
Unfortunately, right. Then a lot of suffering takes place and a lot of unnecessary hospitalizations and catastrophic situations. I mean, people tend to not want to bother with or not go to check out things. I'd rather people come and it turns out to be nothing
Mhm.
than see them in the hospital nearly dead and I have to like spend days or weeks trying to bring them back to where they were
Yeah.
previously.
So some of the questions you should be asking yourself if you have a chronic disease and you're wondering how in control is it is uh, how often do I have a flare up? How often versus how often am I seeing my doctor? Are all my medications having the full desired effect? Is my diet or fatigue affecting my daily schedule? Have I been confused or frustrated with what are usually simple tasks lately? Am I taking all my medications regularly? How often are flares interrupting my school or work? And what could happen if I don't treat my symptoms?
I think those are all great points, and they bear some thinking and notation. Let's face it, again, like I said, if you're going to be your own advocate, you need to keep a diary or running commentary, because how can you really remember how I felt last in December 10th or something?
I can't
Was I?
remember how I felt from one
Yes,
month to another. It's just a whole
right.
mess of just
So if
panic.
you have no documentation and nothing you can look back and say, oh yes, this is pretty typical for my disease course, or no, I wasn't having anything like that, then you're really at a major disadvantage. So keeping documentation of what's happened to you, in other words, the way you feel, I think is important. Your own signs and symptoms. Did I have this rash over here on my collarbone back then? Yes. Oh yeah, I've had that. Okay, fine. Did I have whatever it is, fill in the blank. But without a diary, um, I really don't think that you can keep any tabs on it. And the same goes for you know food intake and medication. I used to eat this and I felt better. I used to eat that and I remember getting sick. Or a couple of times I ended up in the bathroom all night, and now I realize it was after eating this because I took notes on it. The doctor just cannot detect that type of pattern. I mean, you have to provide that information. And if you're not taking sufficient time and effort to note those things down, your care won't be optimum.
So let's talk about the chronic disease cycle. And I know this is a little bit small on everyone's screen, so I'll just go ahead and read that for you. It says fatigue can lead to, lack of exercise can lead to, muscular atrophy can lead to, pain can lead to, multiple medications can lead to fatigue.
Yeah. Well, as we all know, being out of shape can lead to fatigue, and everybody has their personal range of fitness. It may not be world class athlete, but it may be either the best for you, or mediocre for you, or poor for you. I think perfect example is I sent you to cardiac rehab about 3 or 4 months ago, and you were making tremendous progress, and you could see you were walking faster and longer and harder. And then you got sidetracked for a reason. Now you're back to cardiac rehab, and you realize, oh my God, I lost all of that.
Yeah.
I'm walking 1 mile an hour on a flat treadmill for 15 minutes now. So you can see the fitness spectrum right there, and that's certainly just one aspect of it. But trying to stay all the time at the upper end of your own range, I think, is really important. So if you can't do much more than roll off the bed and make it to the bathroom and back, well, roll off the bed an extra time a day or something. And I mean, just do something to try to keep the blood flowing and gravity doing what it's supposed to do on the vascular system, and moving. And you can get outside and get fresh air, that's even better.
Yeah.
Some sunshine. But certainly you have to maximize your own range, and there are going to be times when disease flare-ups make it impossible to virtually move. But then you have to take full advantage of the times when you do feel better, and really get out there and try to improve your mental and physical condition. So it says lack of exercise can lead to muscular atrophy, can lead to pain, et cetera, et cetera. Proof of concept, a lot of this information comes from space flight studies, aerospace medicine, where they're working with extremely fit astronauts in zero gravity and conditions like that. What can happen when they're not using the muscles? They're not in a vertical position. There's no gravitational pull. The heart weakens, the muscles weaken, the digestive organs weaken, and that it's all pretty well documented what happens under those um, artificial or laboratory type conditions. But that's what's happening to a lot of people out there who are not moving or taking or whatnot. And like I said, there's a lot of measurable physiologic deterioration that can be improved.
So back to the idea of having those multiple chronic illnesses. These were just some good summarizing tips, which is having one chronic disease may ultimately lead to a second one. To be aware of a change in symptoms to indicate a second illness. to be vigilant about your regular exams and tests, to know what is your normal and your abnormal, and follow your instinct. And to be aggressive with your treatment so that if you feel as though something has changed and something is wrong, that you insist on further testing and treatment.
I think that's important, and I think you need to not be embarrassed. Call your doctor or go to see them. And if you're concerned about something because you may have developed a new problem and they're not going to know about it, they don't see you on a daily basis. You have to be the one who detects changes in trends that
Mm-hmm.
may indicate new problems. Something like, suddenly developing kidney failure or,
I would say
again,
it's a problem.
right, but you won't necessarily know, and
Mm-hmm.
they certainly won't know, particularly if they're seeing you once or twice a year. They're not going to detect it until it's advanced. On the other hand, if you find some, I'd much rather see somebody who comes in, has nothing wrong, and needs reassurance than I would to see somebody who's in dire straits and whose conditions are way out of control, and now I have to take a lot of corrective actions fast. Again, as a physician on my schedule, I'd rather see people who are well all day, and we're talking about prevention or keeping things well rather than extremely sick,
Mm-hmm.
complicated problems that have just been let go.
I like that the way you summed it up, which is it's better to be safe than to suffer.
Absolutely.
All right. So, lastly, before we answer some of these questions, let's talk for a minute about the disadvantages of the current healthcare system for chronically ill patients. What is the problem?
Well, the problem, as we mentioned earlier, is I think is access. If you have insurance, it may not allow you a lot of time. The offices are very crowded. You got to understand medical economics now. Private practice is, less and less and less reimbursement, and more and more and more overhead. So a lot of offices have responded and by upping the volume years ago.
MSNBC just finished a report saying that with Obamacare coming into place, by next year we may be just at 40% of patients will not have a family internist available. That we are 40%. That we are.
Unfortunately,
Yeah.
that's really bad news because going to a specialist does not give you any kind of ongoing care unless you have
Right.
something very particular and it's a certain situation where it's become a friend or someone who's assumed the primary role for your care. But that's really not what their role is supposed to be. They're supposed to be consultants for difficult situations that come up. But someone has to centralize the care. Someone has to keep tabs on what everybody is doing. That's one of the roles I look upon myself as an internist, is coordinating what everybody else is doing with this patient and making sure that they're on the same page, not working at cross purposes, and not doing things that I think are pointless, useless, or outright dangerous for questionable motives, whether it's money or lack of, I see a lot of times just lack of competency on the part of some of the the consulting doctors, and they're getting tests because they don't know what's going on or what to do, and sometimes I can see that it's a competency question. But as a patient, you can't tell if they know what you're saying to them and know what's wrong with you and understand fully what they're doing, so their advice may be, questionable or useless. And so someone has to be the patient advocate or ombudsman. I think the internist family practice doctor should be, connected in um, taking care of you, and that taking care of you extends to in your interactions with the medical system. In the hospital, patients end up in the hospital. I have to run around the hospital and watch the nurses and the pharmacy and the lab and the x-ray department. Sometimes they'll do really crazy or inappropriate things if I'm not watching carefully. So it's a dangerous place to be. You really need somebody watching your back in the hospital. So again, it all goes back to relationships. If you've established that relationship and they know who you are and you have a good rapport, that's invaluable in dealing with the whole establishment.
Okay, all right. Well, as you can see again, those are the links for the handouts, which are available online on Dr. Santa Maria's website, which is santamariamedicine.com. Now we're going to take a look at some of your questions. So obviously, Dr. Santa Maria has done several webinars before on POTS, which is postural orthostatic tachycardia syndrome. And you have a lot of your fans in here today for that, so we have a couple of POTS questions.
Okay.
So Colleen from Ontario says, I have POTS and a provisional diagnosis of Addison's disease after losing a left kidney. The specialists want me to wait 8 months for an appointment with an endocrinologist. Holy crap. But I am quite sick and losing 1 pound a day. How can I gain weight or retain more fluid without Florinef? The doctor won't give me any Florinef, even though I am under 100 pounds now and losing a lot of fluid.
Wow.
Obviously, some of these questions are like very complicated. And
Well,
we're not
I mean,
gonna have
that's
time
it, but
to-
that's not an
Yeah.
unusual set of circumstances, you know.
Mhm.
I'm sick as hell,
8
and
months
no
to
one's
see
paying
an
attention to me.
endocrinologist? That
I
sounds
don't know
crazy.
if that's Canadian standard or what, but you know, certainly there are healthcare systems like that. And unfortunately, she's asking, how can I take care of myself, not knowing what's wrong with me,
Right.
in essence, and that's really a difficult one. You need to know. I mean, she raised the question of, do I have adrenal gland failure, Addison's disease? Um, and if she has adrenal gland failure, that's going to be really difficult to just deal with. She mentioned Florinef, which is one of the hormones produced by the adrenal gland, and do I need supplements? You need a diagnosis, let's face it. You know, that's a dangerous condition, and I'm sure she's fully aware of that, and she probably feels poorly because of it, but not getting to an endocrinologist for 8 months with adrenal insufficiency is really unfortunate. That's not something you can look up online or WebMD or in a book or decide, you know, I'll just take more salt or do more water, because that's a complicated condition. So if a patient, to sum up, patient like that came to me, I would get on the phone, I would call the endocrinologist, and I would say, I know you're busy. I have a patient with presumptive Addison's disease, needs to be seen. They're sick. There's problems. I'm having difficulty with management. When can you get them in? In other words, I use my network to call in favors when needs be. When someone is acutely ill and things are not going well, I'll get on the phone personally and call the other doctors and say, this is important, see them soon. Because they're getting information filtered from their front desk or not getting anything at all. People are calling up, they may never hear about it. You make an appointment 8 months down the line, of course, they have no idea who you are or what's going on with you.
Mm-hmm.
So if someone doesn't intercede, that's a problem. So this person, just to sum up, this person that's calling, if they have access to an emergency room, really ought to be checking in there. And that's one way to get action. And it sounds like this person needs action.
Yeah. So this is a question I know you've answered before in some of our webinars. Lindsay is asking, I'm in my 30s and have POTS, which I developed a few years ago. I don't know what caused my POTS or if I have another illness that may have caused it. My doctor said that it doesn't matter, but from what I understand, POTS is usually caused by something. Should I be pushing for testing for other illnesses without knowing what those illnesses might be?
The answer to this question is what I had in mind when I said, if you can get away from an HMO insurance, get away from it, because this is exactly the kind of scenario where they don't want to run tests, they don't want to spend money, they don't want to send you to specialists. They would rather just wave their hand and say, oh, you have POTS, you know, drink a lot of fluid and salt. You know, POTS, which is postural orthostatic tachycardia syndrome, is really a final common pathway of a lot of conditions or associated with a lot of conditions. So it's a set of signs and symptoms that can be associated with a whole range of illnesses that can be diagnosed and treated. I'm in favor of trying to find out what other conditions may have precipitated the POTS, rather than just saying, you have POTS, that's your disease, that's what we're treating you for, end of story. I think that Um, everything is connected clearly, and that may just be the tip of some iceberg that really needs to be investigated further. So, yes, I am in favor of finding out what other conditions may have been associated or might be associated. And even if nothing comes up, if we can test a variety of different things and come up negative or empty, that information is going to be useful 3 years down the line, 5 years down the line. When you're older and there's more problems, they can look back and say, well, at this point in your life, you did not have this, but now we see the test is positive, or now it suggests that you are developing this. And, so baseline data is valuable too. And again, if that baseline data is obtained and just vanishes and you change doctors or move to another state, it's going to be completely worthless. So you have to keep copies of that in your own medical record that you should maintain personally. You could say, well, look, doctor, when I was 30, they tested me for Sjogren's. It was negative, but now I'm wondering. I have very dry eyes. I went to the ophthalmologist. They told me something like that. So baselines, even negative baselines, are valuable information.
Okay. Claire from Texas, my daughter has POTS and severe fatigue. What is the best treatment for fatigue? POTS. She's also she's currently on Florinef and occasionally on Midodrine.
So as we know, maintaining hydration is obviously critical. We also talked a few minutes ago about exercise and how being sedentary and horizontal kind of exacerbates the whole cycle.
And I'm going to just say it because this is what every POTS patient is thinking. I can't exercise because
Right.
I can't stand up.
No, I understand
Yeah.
that. Get a laying down exercise,
There, and that's what cardiac rehab is, and we had discussed that a little bit earlier. But many hospitals have cardiac rehab programs where you can go in and you can start in exercises where you're sitting down and slowly and gradually and safely work your way up to exercise that's really going to help you eliminate that fatigue.
I mean, you do the best you can. I understand fully that there are people who exercising even a little bit, like going to the bathroom, creates profound fatigue.
And if you're not on the right medication, then
Certainly that'll
you might
exacerbate
not
it.
be ready to exercise.
There are people who just lifting something really insignificant creates muscle pain. I understand all of that. But what are your alternatives if you don't use it? Obviously, you lose it further. So if it's bed exercises or lifting your head up and down or curling your arms, something. My old patients, the 90-year-olds, do bed exercises before they get out of bed in the morning. They move their legs up and down or twist side to side. They find ways to do things with their pain and their instability that are exercise. They go to chair exercise classes. They go to easy yoga and water aerobics and a lot of different things that you may consider to be too easy or worthless or beneath you. But my suggestion is explore all of that stuff so that you try to.
POTS tends to come on very quickly for most people, and we've heard from many people that were athletes before, and then suddenly they literally woke up one day with POTS and could not do their normal routine at all. And I think that's where a lot of the embarrassment might come in when you think of doing these like simple exercises. But this really is a debilitating condition that needs to be slowly and steadily.
Right, so you're wearing out, you're deconditioning as you go along, and then the question at some point becomes, this is my underlying disease, or is this, my lack of conditioning? And of course, there's elements of both in every condition, in every case. So you just do the best you can to try to minimize that, even if you have to have somebody else exercise your legs or do something.
Yeah.
It's really, we harp on that all the time, but there's a reason for that. And like I said, studies in space have shown that internal organs weaken from lack of movement and exercise. So do the best you can. I know it's difficult at times.
So there are a couple of handouts that we didn't have a chance to go over today, but you can see them on the website, including questions you can ask a new physician, what are my rights as a patient, the chronic disease cycle, and for people with chronic illness, what is an emergency situation? These are all available on www.santamariamedicine.com.
Right.
underneath support groups and support group handouts.
Mhm.
So if there are no more questions, then we just want to say thank you for attending. And oh, we have one more question. What should
Okay.
you look for in a neurologist for POTS syndrome?
For POTS?
Yeah.
Yeah, for those of you who don't know what POTS is a nervous system disease in essence. It's dysfunctional autonomic or automatic nervous system. Um, I've spoken to neurologists who have no idea what POTS is or anything about it, and then there are other neurologists who claim to know something about it and don't seem to produce when the patients actually get in there. But a savvy neurologist will know what the autonomic nervous system dysfunction is, and they will actually, you come in and say, I think I have autonomic neuropathy. They'll jump right in and say and ask a series of questions. I think the leading questions, even that you'll get from the front desk, are very revealing. If you call up an office and you say, I'd like to see the doctor, I've been referred, I have POTS. If they start asking you questions, okay, I understand that. Are you having a lot of trouble with fast heartbeat? Are you having migraine headaches? Are you having gastroparesis? Are you having difficulty voiding? Are you having pains and burning in your legs and hands? You know right away. They know they're on their game. They know what they're talking about, and that you stand to have a good experience in that office. If they say, could you spell that for me? I'm not sure. POTS. You're in trouble probably right away. So that's not a good sign. You have to look for the signs and leading indicators. You've been there. I could see that. You know what I'm talking about, right? So
All right, so thank you so much for coming.
thank
You
you.
can email us at potsresearchgroup@yahoo.com for questions for our next webinar, which will happen mid-next month. Make sure to visit santamariamedicine.com, and thank you so much.
Thank you.